for 2 months, 15 milligram for 2 months, 10 milligram for 1 month, and 5 milligram followed by maybe a couple of weeks of 2.5 milligram or 5 milligram alternate day to complete 6 months of therapy. That is what we used in Sarcot. The other arm, the 40 milligram arm, was 40 milligram 1 month, 30 milligram 1 month, 20 milligram 1 month, 15 milligram 1 month, 10 and 5 milligram 1 month each. So both were comparable.
Okay, we'll go to the next talk by Dr. Dhooria himself. Hypersensitivity pneumonitis.
So I'll now talk on hypersensitivity pneumonitis, and we'll discuss the diagnostic approach and treatment principles. As compared to sarcoid, this disease is much less investigated, especially in terms of treatment. So the outline of my talk will be that we'll first talk about the definition of hypersensitivity pneumonitis. Next we'll talk some bit about the burden in India, exposure assessment tools, the radiology of HP, histology, and then something about treatment. So the diagnosis, the key to diagnosis of HP lies in its definition. So again, we have a guideline on HP which came in 2020. So 2020 can be called a watershed year because in this year several guidelines on different DPLDs came along, 2020, 2021. And HP also we have a good expert like scientifically done evidence-based guideline which never existed before this period. So the guideline defines HP as an inflammatory and or fibrotic disease. So look at the red marked terms because they are very important. Of the lung parenchyma, but also of the small airways. It is typically caused by an immune mediated response to an overt or occult inhaled antigen in susceptible individuals. So these are the keywords: inflammatory or fibrotic disease, involves both the lung parenchyma and small airways. It's immune mediated, it is caused by an inhaled antigen, which is an organic antigen, and it occurs in susceptible individuals. So we are a country of farmers, of pigeon lovers who breed pigeons or feed pigeons, of cattle worshippers. So we have a lot of cattle refuse where people work in enclosed areas with such kind of an environment. And we love mold in our house. It doesn't matter to us if the entire wall is damp, and we easily live with such conditions sometimes. So these are all exposures that cause risk of developing hypersensitivity pneumonitis in individuals who are susceptible. So these are common exposures, but HP is an uncommon disease. So these exposures will not cause HP in most of the exposed subjects, but in a minority they can cause. So this was the paper I was talking about in my last talk also, which we published a couple of years back. And for the first time we looked at the incidence, prevalence and national burden of various interstitial lung diseases in India. We had about 2,000 subjects from our center. We combined 1,000 subjects from the ILD India registry, and so that we had about 3,000 subjects to estimate the burden. So for HP we found an incidence of about 2 to 3 per 100,000 per year, a prevalence of about 8 to 12 per 100,000 population. So it leads to a burden of about more than a 1.5 lakh cases. So it's a significant burden if we take all the cases together in India, and so HP must be a disease to focus on. So how to diagnose HP? Again, coming back to this statement, and I'll take up many recommendations from this particular clinical practice guideline. So the most important change in this guideline is that previously we used to classify HP as acute and subacute and chronic. So any HP that occurred within a few days of exposure, which presented very acutely, just like an ARDS-like presentation, so a massive exposure to an organic antigen, and patient lands up in the emergency with bilateral lung infiltrates and with hypoxemia, with some fever, some other symptoms of systemic inflammation, and such a disease was called acute HP. It's a rare presentation and it may be very difficult to pick up really, because such presentations may just get treated like an average ARDS patient unless you are very careful about eliciting an exposure history in most of your ARDS patients. The second presentation is subacute presentation, where you have kind of slow protracted exposure to antigens which occurs over weeks to months, and then the patient develops cough and dyspnea. And if you do a chest x-ray, you might find some kind of haze, some ill-defined densities which you are not able to really pick up. And then once you do a thin section CT, then you could see a few ill-defined nodules in the central lobular region. Not only a few, maybe extensive nodules also, but without signs of fibrosis. So that was the subacute presentation which occurred with HP. And chronic presentation is with mostly very long exposures, so mostly occupational exposures or residential exposures to molds and birds, which lead to a kind of typical ILD-like presentation of chronic cough and dyspnea. And on the radiology, you'll find signs of fibrosis like architectural distortion, traction bronchiectasis, honeycombing, etc. But the new classification is just to divide it between non-fibrotic and fibrotic HP, because sometimes the history of exposure and the duration of symptoms history is not very reliable. So just taking the cutoff of 6 months, which was previously taken to divide subacute and chronic HP, is not good enough to really understand the real clinical implications of that particular category of HP. But with fibrotic and non-fibrotic HP, we know that fibrotic HP is going to be a chronic disease which is not going to resolve, while non-fibrotic HP has a good chance of complete resolution and cessation of treatment. So eliciting an exposure history is very important, and this has been the focus of this guideline, that how to really get to whether an exposure is present in a patient's environment or not. And there are various studies which have looked at the kind of exposures that might occur which can give rise to HP, and also in how many patients, what proportion of patients are you able to pick up exposures. So it's a wide range of 30 to 70%, but mostly it is the thumb rule is that half the patients you will be able to pick up the real exposure, but half the patients you will not be able to identify exposures. So how can it be done? It can be done by taking a good history of exposures. So you could go ahead with certain questionnaires. So they can be region-specific questionnaires. They are available in the literature, used by several research studies. The ILD India registry by Dr. Sheetu Singh and group also had a long kind of questionnaire of exposure assessment. But it is often not feasible to really fill it up, those questionnaires, in a busy OPD sitting with the patient. To hand it out to the patient again creates problems, because some patients may not really understand the significance of each exposure. So exposure questionnaires, though exhaustive, may not sometimes be very usable in the kind of population we have, especially patients who are illiterate. So I believe that a sequential, focused and intuitive collection of information may be more informative. So you could have a set of exposure items with you, or if you can remember them all, and then you can go ahead with sequential questioning of patients to really get to the real exposure. And it is not only important to ask the history of the type of exposure, but also the intensity of exposure. So a very minimal exposure to, say, birds, so it will be present in everybody, in each of us. Some pigeons will be, some other birds will be visiting our balconies, etc. Mostly that will not cause HP, although in rare cases it has been documented that it could lead to sensitization, but in most of the cases very mild exposures may not be important. Similarly, exposure to air coolers and air conditioners, which was an important cause of HP in the ILD India registry, that creates a problem, because everybody in India is now using air coolers or air conditioners. So just if you have an air cooler at home or air conditioner at home, that does not say that you have HP due to that particular thing. So you really have to be careful to document that there is mold infestation in your humidifiers or air coolers, conditioners, or if there is mold infestation on your damp walls of your house. So the history taking has to be really very in depth and exhaustive. And then removal from exposure can be a good way to ascertain whether a particular exposure is responsible for the symptoms or not. So if somebody is living in a mold infested house, he shifts to another location and the symptoms come down, then you really have a better evidence to associate that exposure with the HP-like symptoms. Then again, temporal association and seasonality may be important. So several of our patients will typically give a history, those who are farmers who get finally diagnosed with confident HP diagnosis. So they will give a history that during the harvesting season they used to have bad dyspnea, and mostly it gets treated as asthma during the initial periods, and finally sometimes they'll land up with bad fibrotic HP because of the particular seasonality, which could make the physician confuse it with asthma. So seasonality is a very important feature, especially with the farming related work. So it is important to pick up HP, but also to differentiate it from other etiologies of ILD. So the other etiologies of ILD is simple to remember. So mostly we say that there are 200 to 300 kinds of ILDs, but mostly the major ILDs can be reduced to 5 subgroups: sarcoid, IPF, CTD-ILD, HP, and other ILDs. So if you go ahead with the history of connective tissue disease, of drugs that can cause ILD, like a prolonged exposure to nitrofurantoin, to chemotherapeutic agents, to amiodarone, to methotrexate, so that would give you an idea of drug-related ILD. Environmental exposures include both organic dusts and inorganic dusts. They could be occupational, or they could be residential, or due to a hobby like pigeon breeding or feeding. So again, that history is the most important for HP. And familial disease could give you a clue that it may all be genetic without any other particular risk factors for various ILDs like smoking, CTDs, or environmental exposures. So what are the lab tests? So if you do a chest X-ray, you could land up with such an X-ray where you might have various differentials. So it could be sarcoid, it could be hypersensitivity pneumonitis, it could even be tuberculosis. So on a chest X-ray, the findings will be quite non-specific. Further investigations will include spirometry to really know what kind of ventilatory defect it is. So we looked at our data and we saw that in HP, mostly the defect is restrictive, and we mostly get patients during the later stages because it's a referral center. So mostly they have already some amount of lung restriction. 10% of patients may have an obstructive defect, while 10% may still have a normal spirometry. DLCO is really desirable if available and standardized, and it might help you to really uncover how much is the diffusion defect, and it can help you follow up with treatment, for treatment response and prognosis. Lung volumes if required. For example, if you really suspect both the restrictive and obstructive components in a patient, and you really have a clinical question to answer, or maybe a case report to publish, then go ahead with lung volumes, but usually not required in all cases. Again, a high resolution CT scan, which was the previous terminology, and now we use volumetric multi-detector CT scan with thin section reconstruction, which should be used for any kind of diagnosis of ILD subtypes. The autoantibodies that we routinely perform in an undiagnosed case of ILD are ANA, rheumatoid factor, anti-CCP, and ANCA. So this is the routine that we do in our center as part of protocol. But if CTDs are absolutely not a suspicion, you may absolutely avoid these antibodies. But again, for data collection and for the uniformity of the algorithm that we use for ILD subtype diagnosis, we at least do an anti-nuclear antibody by immunofluorescence and a rheumatoid factor. So there are certain tests to identify exposures which are very important in case of HP. So there are specific inhalational challenge tests which are, I don't think, available in our country. Even in other countries, they are performed mostly in a research lab setting, routinely not available, difficult to perform, and no standardization is available, no cutoffs are available. Lymphocyte proliferation test, again, taking BAL lymphocytes and exposing them to antigens. It is again very cumbersome, very resource intensive, needs a very special laboratory support. So they are impractical. What is practical in our setup is doing specific IgGs to environmental antigens. They can be done in ELISA, which was the previous technique used, but now they are done by immunocap method, which is a fluorescent enzyme immunoassay It is it is provided by some platforms, but most commonly used platform is the FADIA platform, for which is used for doing tests for ABP and CP also, for assessing the IgE and IgE antibodies against Aspergillus fumigatus there. So that is the most commonly available test now. There are no cutoffs available with specific IgG testing, but we have recently attempted to propose some cutoffs using data from healthy controls, and which we are soon going to publish. The paper is under review, is going to be submitted for publication, and we have assessed the cutoffs for 4 molds, that is Aspergillus fumigatus, Penicillium chrysogenum, Cladosporium herbarium, and Micropolyspora feni. So you'll see that paper soon, and we'll have those cutoffs at least to use it in our clinical practice. But even with those cutoffs, we found that the sensitivity in our study was only 57%, and the specificity was only 78%. So about 20% false positivity rate if we just use the specific IgG testing as the sole parameter of diagnosing HP, and sensitivity of only picking up just about half the patients. So the other things in HP diagnosis, the other components really have to be put into a multi-component diagnosis of HP. So as I said, no well-defined cutoffs yet. A positive test does not confirm HP. So we found a positive predictive value of about 80 to 90% with various combinations of tests in our particular study. A negative test does not exclude HP or even exposure. So that is true, because the negative predictive value was only about 60%. So if you have a negative HP panel, that does not rule out HP at all. And so it should be interpreted in the light of other clinical and laboratory data. So what does the radiology show in case of HP? So I go back to the guideline which has been recently published. So HP is divided into non-fibrotic HP and fibrotic HP. The radiology can be classified into typical HP and compatible with HP, with non-fibrotic HP. And with fibrotic HP, you can have typical HP, compatible with HP, and indeterminate for HP. So typical non-fibrotic HP, as I told you, that the typical subacute HP of erstwhile terminology. So these are the ill-defined centrilobular nodules. So you can see that they are not well-defined as you see in cases of, say, sarcoidosis. So here is a case of sarcoid where there are this kind of septal nodules, and these are several well-defined nodules you can see all over, while this is a case of hypersensitivity pneumonitis. So it basically has to show one or more signs of parenchymal infiltration. So if you go back to the original definition, so it's an inflammatory or fibrotic disorder that we discussed, that could be non-fibrotic, fibrotic. It is immune mediated, so we discussed that it is mediated by certain kinds of immunoglobulins G. It occurs due to inhaled antigen. We have discussed the inhaled antigens which may be responsible, and now we discussed that it might be, it involves the parenchyma as well as the small airways. So parenchyma infiltration is represented by ground glass opacities or ill-defined nodules, and mosaic attenuation. I'll show you the mosaic attenuation later. And one or more signs of small airway disease. So the ill-defined centrilobular nodules are actually in the small airways, which go to the centrilobular region, and there, because there is airway-centric inflammation, lymphocytic infiltration with some amount of giant cells or ill-defined granulomas, so that causes this ill-defined centrilobular nodules. Then air trapping occurs on expiratory scans. So when these small bronchioles around which there is inflammation, when they slowly go into more fibrosis and more constriction, then this kind of air trapping would develop, especially seen on expiratory scans. And the distribution in these cases is mostly diffuse. So subacute or non-fibrotic HP is a diffusely involving lung disease, or sometimes it may even be lower lobe predominant. So here you can appreciate the mosaic attenuation. So these are the areas which are grayer, these are blacker areas. So the blacker areas are the abnormal areas because the terminal bronchiole there is obstructed. So when the patient takes a good deep breath and tries to exhale, the air gets trapped due to the obstruction of the terminal bronchiole there. So that causes this kind of an air trapping on expiratory scans. And even on inspiratory scan, there may be contrast differences which are called mosaic attenuation. So here we have airspace consolidation with sometimes there will be lung cysts and the distribution will be lower lobe predominant or peribronchovascular. So this is called a compatible with non-fibrotic HP pattern. But this, especially airspace consolidation, is not a very typical feature and not very common with HP. So be very careful to rule out organizing pneumonia or even sarcoidosis sometimes whenever you see consolidation in patients with suspected HP. So typical fibrotic HP would look like this. So there'll be signs of fibrosis in terms of some volume loss, architectural distortion, this kind of post traction or cicatricial enlarged air spaces may form, which may just look like a cavity or a bulla. There'll be irregular lines, so you can see irregular lines all over. There's architectural distortion. You can see that this upper part of the lung is distorted. Traction bronchiectasis and honeycombing are typical signs of lung fibrosis. The distribution here is random, but it may be mid-lung zone predominant or upper lobe predominant. And again, signs of small airway disease are very important for defining typical or compatible HP pattern. So again, ill-defined centrilobular nodules, mosaic attenuation, there's something called a triple density sign, and air trapping. So I'll show you the triple density sign. So here you can see that this is ground glass area, so a lot of gray and whitish patches there. Then this may be a normal area of the lung, and this is a area with air trapping. So air trapping, normal area, and then areas of ground glass attenuation. So this may be called a triple density sign. Then compatible with fibrotic HP pattern. So if there are variant patterns of fibrosis, so we discussed that upper mid-zone lung predominant fibrosis is typical HP, but if there are other patterns along with signs of small airway disease, then it is called compatible pattern with fibrotic HP. And these are indeterminate patterns. So if they don't fit with typical or compatible patterns, so it could be a UIP pattern, it could be a typical fibrotic NSIP pattern, or it could be an organizing pneumonia-like pattern. So these patterns can exist in HP, but then you will need a biopsy to really make a diagnosis of HP. And without that, you cannot fit them into an HP diagnosis, because UIP could be due to various other ILDs like IPF or CTD ILD. So all these patterns could be very well due to CTD ILD. So always you need a biopsy and a good exposure assessment. So what are the mimics of HP on HRCT scans? Fibrotic sarcoid, as we discussed, it is also an upper lobe predominant disease, just like HP. And even fibrotic sarcoid involves airways. So air trapping may be there with fibrotic sarcoid also. CTD ILD with airway involvement. For example, rheumatoid arthritis related ILD. It can have typical signs of fibrosis, which may be in a UIP-like pattern, it may be an NSIP-like pattern, sometimes it may be upper lobe predominant. So 10 to 15% of CTD ILDs may occur only in the upper lobes or predominantly in the upper lobes. Once you have a small airway involvement also with the ILD, so small airway involvement is also seen with CTD ILDs. So once you have a fibrotic lung disease with small airway involvement, it becomes a mimic of hypersensitivity pneumonitis. The third is IPF, because sometimes IPF and HP may be indistinguishable. Especially if on CT you are not able to find mosaic attenuation or air trapping, then you might have a problem. Especially in young patients, you will not suspect IPF. So a 40-year-old male comes to you with a UIP pattern. So IPF is not the one which you will suspect. You will think of a CTD ILD or HP, or maybe a familial disease. So then if you investigate further, if you say find a good exposure in his historically, and you also find a serum specific IgG to a fungus, then you go ahead with a biopsy and prove that this patient has hypersensitivity pneumonitis rather than IPF. The third is small airway diseases. So once you are in the practice of doing expiratory scans for ILD, once in a while you will find a scan which has a lot of air trapping. But if you don't look carefully at the patient's history and then respiratory scan, sometimes you can misdiagnose asthma as HP, because severe asthma will have a lot of air trapping on expiratory scans, and you may mistake it for ground glassing and mosaic attenuation due to HP. So it is very important that you first rule out asthma in such cases. So a good inspiratory scan will not show ground glassing in asthma. So the GGOs are not a finding in pure asthma. So be careful to have both the inspiratory and the expiratory scan when evaluating for hypersensitivity pneumonitis. So this is the kind of key that the guideline provides, and you can keep it in your mobile or print it and stick it up in your outpatient so that it is very easy to follow, because it is difficult to remember. So once you have an HRCT, you look at the pattern. If it is typical for HP, or whether it is compatible with HP or indeterminate for HP. So I'll have you remember that typical for HP pattern means there is either upper lobe fibrosis or ground glassing, and there is small airway involvement. So that is a typical pattern for HP. So once you have a typical pattern for HP and you have a clear exposure history, for example, you have somebody who feeds pigeons every day for several months to years, then already you have a moderate confidence diagnosis of HP. So you see this moderate confidence even without a BAL or further biopsy. But if you don't have an exposure history, then even with a typical CT pattern, the diagnosis is only low confidence. So I would say that at least go for a moderate to high confidence diagnosis or a definite diagnosis. A low confidence diagnosis is not preferred because sometimes other diseases which are mimics of HP could give you a picture which is like low confidence HP. So try to go for a moderate to high confidence in this particular setup. So if you have a typical HP CT and an exposure history, then moderate confidence is made. You may not need anything else if there are no differentials. But in any other case, you may need to do some kind of a procedure like bronchoscopic biopsy or a bronchoalveolar lavage. So once you do a bronchoalveolar lavage and you find lymphocytosis. So what is BAL lymphocytosis? The guideline says that if you have a white blood cell count, a differential white blood cell count of a BAL, and if you have 30% or more lymphocytes, then it is called BAL lymphocytosis. So if you have BAL lymphocytosis, then the confidence is high in the first scenario where we discussed that typical CT, exposure history, BAL lymphocytosis, a high confidence. So in every case, the BAL lymphocytosis pushes up the degree of confidence in the diagnosis, right? And the best thing to do would be a lung biopsy. So if you go ahead with a lung biopsy and you have typical findings of HP there, then the diagnosis is definite in most of the cases. Even if you don't have a typical CT, even if you don't have exposure history, but if you have a clear HP, typical HP histopathology, then there are hardly any differentials left. So you can make a definite diagnosis of HP. So just remember that HP diagnosis can be made with various degrees of confidence. But the higher the confidence, the more sure you are in your treatment also, because treatment is very challenging in HP. So if you are not sure of your diagnosis, you at every step in treatment you'll get confused. So try to do biopsies in non-typical cases or in the absence of exposure so that you can get to a definite diagnosis. BAL lymphocytosis has its problems because there's no clear cutoff defined. 20%, 25, 30, 40, 50% are various cutoffs used in literature. The guideline picks up 30% as the most favored one, but again, no particular cutoff is sacrosanct. So it should not be used in isolation because BAL lymphocytosis is also seen with sarcoidosis, with organizing pneumonia. So always combine it with the radiologic findings, the exposure history. I'll just be a little quicker now with my slides. So lung biopsy, TBLB will give you a 30 to 40% yield, and that too in non-fibrotic HP. So do a standard conventional forceps TBLB only in non-fibrotic HP. With fibrotic HP, go ahead with a bronchoscopic lung cryobiopsy, which gives you a good yield of 80 to 90%. But if you have a problem with differentiating it from IPF, say a 60-year-old farmer smoker comes to you with a UIP pattern with some airway, small airway involvement, then sometimes it's an issue, and a good TBLC may also help you differentiate, but there sometimes you will need a good surgical lung biopsy to really pinpoint whether it is fibrotic HP or IPF. These are some unpublished data from our center. We looked at about 100 patients of HP and we looked at the profile. So about 15% were non-fibrotic, but the vast majority were fibrotic. A typical pattern was there in about 70%, and we made a definite diagnosis in about 35%, and a diagnosis with moderate confidence in 37%. So this moderate confidence is mostly those patients who had a typical HPCT and an exposure history, and they were not ready for a biopsy, or they were not fit for a biopsy. So there, the confidence level is moderate confidence. So that is 37% of our patients. Histopathologic features, just remember BIG, big. B is bronchiolitis, I is interstitial lymphoplasmacytic infiltrate, which are airway centered, and G is granulomas. These granulomas are poorly formed. You will never find well formed compact several granulomas in HP. Those are found only in sarcoid, right? So if you have poorly formed granulomas, just a collection of few histiocytes with a single giant cell, that is more likely to be HP rather than any other granulomatous disorder like sarcoid. And in this particular study, which we published in 2019 with our pathologists, about 20% of patients with symptom duration of less than 6 months who would be classified as acute or subacute HP by the older definition were having fibrosis on biopsy. That is why the older definition of acute, subacute and chronic should not be mostly followed, although they can be referred. Those terms can be used just to understand the duration of symptoms, but the standard categorization should be in fibrotic and non-fibrotic HP. And finally, you need multidisciplinary discussion for a confident diagnosis of HP. It doesn't mean that you need MDD in all cases. So if you have a typical CT and exposure which is very clear cut, you may not need MDD. Or if you have done a biopsy, it shows definite HP and the other findings are consistent, then also you don't need an MDD. MDD is required where there is confusion. For example, you did a small biopsy and you found a granuloma, which is, you don't know what kind of granuloma it is. And you have some exposure, which is again not very certain. CT findings are, again, you don't know, they are either here or there. So there you need to have an MDD, and you should always have differentials in mind. For example, CTD-ILD can sometimes be a differential with HP. IPF may be a differential of HP. Sarcoid may be a differential of HP. So to rule out other differential diagnosis, you should hold a MDD with radiologists and pathologists. I have left very little time for treatment because treatment is not evidence-based yet in HP. We just have a good RCT, a small RCT but well-performed RCT of prednisolone versus placebo, which was done in 1992, and it was done for farmer's lung, acute farmer's lung. So it was acute HP or acute subacute HP. So there it was an RCT of 36 patients, which showed that glucocorticoids did cause relief in symptoms and radiologic improvement in the initial part, but the long-term outcomes were not affected by glucocorticoids. After that, we just have retrospective studies of prednisolone and steroid sparing agents, which are mostly in the form of mycophenolate mofetil and azathioprine. There are a few case series with cyclophosphamide, a few case reports or very small case series of rituximab, but again we don't have hard data on that, and they are not recommended as a routine treatment of HP. So the summary of these studies is that for acute, subacute or non-fibrotic HP, you could use just glucocorticoids for about 3 to 6 months. But for more chronic disease and fibrotic disease, you could go ahead with a steroid plus a steroid sparing agent. Again, we in highly fibrotic disease, like in advanced fibrosis, we don't know whether mycophenolate or any kind of immunosuppression will really work. So we really need to find out whether immunosuppression works in fibrotic HP. We have a trial going on at our center. Our center is leading the trial, but it's a multi-center trial. CMC is also a part in this trial. It's called the MycoHype trial, where we are using a combination of mycophenolate and prednisolone and comparing it with a prednisolone alone arm for treating fibrotic HP. Antifibrotics in HP could be, so there are 2 antifibrotics available. They have a good amount of evidence in the treatment of idiopathic pulmonary fibrosis, IPF, nintedanib and birvanidone. So this was the inbuilt study which looked at the use of nintedanib in diseases which had progressive fibrosis but were not IPF. So they excluded all IPF patients, and they only took patients with CTD-ILD, hypersensitivity pneumonitis, sarcoidosis, and occupational lung diseases who were having progressive fibrosis. So there they discovered that nintedanib as compared to placebo is effective in reducing the lung function decline in such progressively fibrosing ILDs or progressive pulmonary fibrosis. So then they did a subgroup analysis, and they looked at just patients with different subgroups of underlying ILDs. So with hypersensitivity pneumonitis, the benefit was similar to the entire group. So there was no difference in the benefit caused by nintedanib in the entire group as compared to hypersensitivity pneumonitis. So we can extrapolate from this that nintedanib will work well even with fibrotic HP. Similar was the case with pirfenidone, but the pirfenidone trial was a shorter trial. It had to be reduced in duration, and finally significant results didn't come out with pirfenidone, but the trends were similar with nintedanib. So if the first choice would be nintedanib as an antifibrotic in HP, but if somebody is not tolerating and you need an antifibrotic, then pirfenidone may not be a bad choice. So the proposed treatment which we commonly use in our practice is that if you have mild non-fibrotic disease, antigen avoidance alone, which I didn't much elaborate on. So sometimes a very mild and early disease could settle with an antigen avoidance alone also. So if you have a clear antigen, for example, again, say a pigeon feeder, and you just tell him to shift to a place where there are no pigeons and there are no even traces of any pigeon related material, then the disease might completely recover. But a few cases will progress despite antigen avoidance. If there is significant inflammatory disease, and especially if the antigen is not identified, go ahead with glucocorticoids for 3 to 6 months. And if there are persistent symptoms, go ahead with adding MMF or azathioprine. With fibrotic disease, you can start with lower doses of glucocorticoids because this disease will not respond much to immunosuppression. So using higher doses and causing more glucocorticoid related side effects is not a good idea. So you could just give low dose glucocorticoid with MMF or AZA. And if progressive fibrosis occurs, then you go ahead with an antifibrotic where nintedanib will be a preferred agent. So the take home from this lecture is that HP is classified into non-fibrotic and fibrotic disease. HRCT may be typical or compatible with HP or sometimes indeterminate where you need a biopsy. Exposure history is a must. Specific IgG antibodies might help. A 30% lymphocytosis on BAL increases the confidence in the diagnosis of HP. If there is no clear diagnosis on the above, then you go ahead with a lung biopsy. Prefer a lung cryobiopsy in all subjects, but with non-fibrotic HP, a TBLB with a conventional forceps may be good enough in about a third to half of the cases. Surgical lung biopsy reserved for cases where you feel that cryobiopsy will not help. And multidisciplinary diagnosis is required, and we must assign a degree of confidence. Regarding treatment, antigen avoidance is supreme. Treat for 6 to 12 months with low-dose glucocorticoids with MMF or azathioprine. Use nintedanib or pirfenidone if extensive fibrosis or progressive fibrosis occurs. Thank you.
Any questions and comments from the host?
Either the lecture was extremely clear or everybody was sleeping.
Sahajal, for progressive pulmonary fibrosis. So it is the same definition as for everything else. Clinical, radiological, physiological. When they fulfill, then in addition to immunosuppression, steroids, as indicated, this also could be added as an agent.
Sir, we don't know actually. Actually, we don't know whether immunosuppression helps in the first place, whether it helps as a part of multi-component treatment with antifibrotics. So our practice is to start with immunosuppression, especially in cases where you see features of both fibrosis and inflammation. So on CT, you try to make out whether there's a lot of ground glassing or not. But we should remember that this is not sacrosanct. Some people would say that, okay, if there's ground glassing, I will give high dose steroid and this. So it does not work always, because sometimes ground glassing and early reticulation could all be due to early fibrosis also. So we have to be careful and really monitor the patient well. Start with glucocorticoids. If it is non-fibrotic HP or a mixed kind of HP with a lot of GGOs, ground glass nodules, then it is supposed to respond to immunosuppression. So there we will start with say a 40 milligram dose of prednisolone, which we'll give for 1 to 2 weeks, then quickly come down to 30 milligram for 2 weeks, and then follow it up with a 20 milligram dose for a month or so. So that is the protocol we are using in the MycoHype trial. If it is a fibrotic disease to start with, but still you see some signs of inflammation, using high dose glucocorticoids may be counterproductive because they will lead to some amount of initial response, but then mostly side effects, and because the treatment will be prolonged, so it will cause further reduced quality of life. So there we generally go with a medium to low dose of prednisolone. We tend to add mycophenolate or azathioprine early in such cases, because if we have decided to give immunosuppression, better give it for 6 months to a year. So better to add MMF or azathioprine either quickly after steroids or at upfront. And once progressive fibrosis occurs, there what we do generally is that if there was an initial response to immunosuppression, say the FVC increased initially, and then it slowly plateaued and then started coming down, and the progression is not very fast. So the thumb rule is that in progressive pulmonary fibrosis or IPF, FVC falls by 200 to 400 ml per year in those who are progressing rapidly. In those who are stable, the FVC fall will be less than 200 ml per year. So if we see a very rapid FVC fall on immunosuppression, there we believe that immunosuppression is not working. So there I would rather add an antifibrotic and slowly taper off immunosuppression, and just leave the patient with say 2.5 to 5 milligram of prednisolone, because it helps with cough control, etc. But if there was an initial good response, if the FVC plateaued for say a year or two, the patient was stable, and then there is a slow decline in FVC, then I would tend to continue lower doses of mycophenolate. For example, the dose we use is 2 gram per day, but a lower dose would be 1 gram per day, and add an antifibrotic and just follow up what happens. If there are drug side effects, then I'll stop MMF. If the patient tolerates the two drugs well, nintedanib and mycophenolate, or mycophenolate and pirfenidone, I will continue with both. So again, nothing is evidence-based. We are trying to generate evidence.
I completely agree. I mean, I'm asking you a question which we battle with in MDDs. So commencement of progressive pulmonary fibrosis treatment doesn't end immunosuppressive treatment, but then needs a relook, and you cautiously continue if you think there is added benefit with immunosuppression.
Yes,
that's what you are saying.
That is how you have summarized it well, sir. That is true.